Welcome to BW Healthcare World. And today is World Lung Cancer Day. And to discuss what genomics, the role that genomics is playing in the field of lung cancer, we have three eminent speakers with us. We have Dr. Sandeep Nayak, who's a director, surgical oncology from Fortis Cancer Institute, Bannerghatta Road, Bangalore. We have Dr. Trinanjan Basu, who's a senior consultant radiation oncologist with HCG Cancer Center, Borivali, Mumbai. And we have Dr. Siddharth Srivastav, who's a consultant at Newberg Center for Genomic Medicine, is also a faculty at the IIT Jodhpur. Thank you so much for taking out time to be with us today. Dr. Nayak, let me begin by asking you, what are the early symptoms to know that one could be suffering from lung cancer, and what should be the immediate step that the patient or the patient's family that needs to do?
First of all, thanks for having me for this panel discussion. So today is Lung Cancer Day, and Lung Cancer Day is to, any day that WHO declares or World Health Organization declares is mainly to create an awareness. It is not like a birthday where you enjoy. It's a day when you, remember a disease so that, you can prevent and reduce the mortality due to that. So in the same line, when I talk about it, the symptoms of lung cancer, or for that matter, any cancer, is related to the organ which is involved. So when we talk about lung, what are the most common, symptoms that anybody gets when there is a lung disease? It is cough, it is breathlessness, it is difficult, you start getting breathless when you walk for some distance. There can be some blood in the sputum, there can be scanty sputum coming out sometimes. So these are all the signs, early symptoms of lung cancer, which, by the way, are the same as any other lung related illness. So this is where it becomes important for you to understand that the indication to go to a doctor and take help or investigate for lung cancer is when the symptoms keep persisting and they don't go away even for 3 weeks, 4 weeks. They just persist and there's no change in the symptoms. You just don't come out of that cough cycle. It just keeps on recurring to you and or worsens. That is when you start approaching a doctor to investigate it further.
So, Dr. Basu, I want to ask you that, lung cancer is, now we are seeing more and more cases of lung cancer coming about. What is the current situation of lung cancer in India? Do we have some numbers that suggest whether it is growing or whether it is on a downward trend?
Hi, thanks for the invite. Like Dr. Sandeep said, since we are discussing on a very important day, so the numbers, see, in India, because still predominantly lung is also a tobacco related disease. Like for head neck cancer in India, because smoking is very, very prevalent. And over the years, the smoking patterns have changed also. Maybe you have a 2 decades or 3 decades back, people of the lower socioeconomic class, they're smoking more due to their job profile or so, but it has completely taken to a new level of fad that, okay, you smoke, there's a style statement to it. Unfortunately, our movies, our media, they kind of glorify smoking to a level that I see in our clinic, the teenagers, the opposite gender, the female smokers, these are very, very prevalent now. There's a trend to that. So still the curves are not declining in India anyways in lung cancer. Rather, I would say it has gone to very, very different age spectrum. At a time when you may be thinking it's a 6-7 decade disease, you can see that in even third decade nowadays, lung cancer, fourth decade, fifth decade are quite common. So curves nowhere decreasing. There are different types which are coming out in lung cancer. Maybe for females, it be some different type if they're non-smoker. So it's quite a prevalent disease, and it's going to be also.
So, Dr. Srivastav, since you've been on the diagnostic side and you're also working on the technology, I want to understand, what have you been able to identify? What are the causes of lung cancer that are specifically prevalent in our country? As I understand that, every country or geographic location has different, impact on the cancer. What is it that is prevalent in our country that is causing or could be causing lung cancer?
Yeah, you know what? I wish I had a very simple answer for you. I think the answer becomes more difficult because in our country, collecting data on a single portal or collecting patient data in grainy details is a very difficult task, tough task. Although some of the registries are being formed, but normally, there are carcinogens, irritants, which continuously comes in contact with the cells of lung, the inner linings of lung. So those cells, when they continuously get irritated, right, or certain carcinogens can pass through those cells, they then start interacting with the DNA. They go inside the cell and then they start interacting with the DNA, where they actually make some changes in the DNA, and because of those changes, some of the normal genes, normally functioning genes, they can become an oncogene. Or, so these oncogenes or the cancer causing genes then can lead to, development of lung cancer. But these carcinogens or, oncogenic agents, some of them people have already identified, like cigarette smoke and maybe pollutants. But a lot of them are not even identified to that great extent. So, there could be multiple reasons, but definitely cigarette smoking and pollutants are on the forefront that we know of.
Dr. Nayak, we had mentioned that there are different kinds of cancer, different kinds of lung cancers that we are seeing today. So, what are the different types of lung cancers that we are seeing in India now? And uh, is there any specific type of lung cancer which is more prevalent? And is there any situation that we can say that this kind of a cancer or this kind of a lung cancer is curable?
Okay, so you have asked me multiple questions in one breath. So, so first part, lung cancer is divided into, see, based on how they appear under the microscope. So that is how they are classified. There, broadly it is called small cell and non-small cell. Under non-small cell, there are multiple types, which I don't want to get into because it's not for general public. But generally, the classification which is followed worldwide. So it doesn't change from place to place or country to country because it's in medical science. It is classified in a particular manner. But are the Indian cancers different from the Western cancers? Yes. The reason, there are some drugs which work very well for India and, say, for example, Eastern population like China and all that, whereas those drugs do not work for the Western population and they have stopped using it. But India is still using it because it works wonderfully well for us. So there are genetic differences in the cancers that we have when you compare to the Western world. Now, you asked me about the curability of cancer. I hope the first part of the question I have answered properly, right? Okay. So the second part of the question you are asking about is the curability. Which are the cancers which are curable? Generally, a type that is first one which I told you, the small cell lung cancer, is generally considered incurable. It is it is incurable because by the time the patient comes, it is already stage 4. It is very, very, very unlikely that a patient with small cell lung cancer will come when it is curable. And that particular type of cancer, 98% of them occur among smokers. There's a very small percentage of small, non-smokers. So it is a completely smokers-associated cancer, and most of them come in stage 4. So it is, if there is a choice, it is better to have a non-small cell lung cancer. And as it goes with all cancers, earlier the stage, that is stage 1, 2, they and to a certain extent 3, do better in the form of survival, or in as it comes to survival, than stage 4. So that is how it is. So, and when we look at stage 1, we look at cure. We are looking at about 80 to 90% chance of cure. Whereas in stage 4, we are trying to give some good quality life to the patient. We are not looking to cure. The good part is, as of today, because of the advancement in the medicines and the type of treatment which is available, we are able to give some of them at least some 3 to 4 years of healthy life. So that difference exists today. But overall, always it is better to diagnose cancer at an earlier stage than a later stage.
Sir, so tell me one thing. You said that most of the cases come to you only when they are in the 4th stage. So do they go undiagnosed, or is there some kind of a they go unnoticed by the patient or their family? And if they do, what is it that they must keep in mind that will alert them that they should go and get themselves tested?
So, see, the unfortunate part of lung cancer is that the symptoms mimic common lung ailments. So, very commonly, what happens is, even when you approach a doctor, say you approach a doctor with the cough or breathlessness, the first diagnosis is asthma or something like that, some allergy. So the patient goes on a chronic treatment on this kind of asthma medicines, these kind of things, and by the time a diagnosis is reached, it's already late. That is how most of the cancers are missed, lung cancers. And other segment which is already usually missed is because they diagnose it as TB, and by the time the patient comes to realize, or the doctor realizes that it is cancer, it's already 2 to 3 months uh, of valuable time which is lost. So these are very common scenarios. So what is the solution for this? Solution is screening. I think you are discussing this, right? Should I talk about screening? You want me to talk about it now only?
Absolutely.
Yeah. So see, the whole idea of screening for lung cancer is to identify those people who are at a higher risk of getting lung cancer, and doing some test which will detect it before the first symptoms start. So that is the whole idea of doing a screening. So who are the most vulnerable population? They are the smokers. So there is a calculation how much smoking and all that. It's all available online. The people who are above the age of 55, there is some evidence to say 45 also. So smokers above the age of 45 or 55, various studies are there. Now, I think they said 30 pack years means, there are calculations which are available for that. And, otherwise asymptomatic, they're doing good, nothing, no symptoms which are there, but they should go for screening because they are the population which are, or people who are at a higher risk. And what is this test that we are talking about? It's a CT scan, which takes about 5 to 10 minutes to perform. It's a low dose CT scan. So person goes into the CT scan, comes out in 5 minutes with no injections, nothing, just lying down, taking a CT scan and coming out. And that can save a significant number of lives. Nearly 20 to 50% of people, can be saved by just that scan. Additional people I'm talking about.
Awesome. So, Dr. Siddharth, I want to ask you that.
Yeah, actually, before we go to this,
Yes.
so just one point I wanted to add was, as Dr. Nayak very rightly pointed that sometimes, the patient, the diagnosis is confused between TB and actual tumor. So one of the things, the reason I want to talk about is that one of the projects that we are doing at IIT is radiomics. Basically, now with the advent of a lot of artificial intelligence and everything, all these machine learning, AI, and deep learning, people use interchangeably. But one project that we are doing is of radiomics, where we are collecting a lot of CT images of patients with cancer diagnosis and with TB, and training models to differentiate, so that to get to a point where a doctor, when confused, they can have some sort of portal where they can upload the picture and could get a suggestion that it looks like 85% tumor versus like 15%. So some of those things are kind of like, people are trying to build some health agents for doctors.
So I also want to ask you one more thing is that, since this topic has been brought up, that there's a delay in diagnosis, and sometimes it is also not diagnosed because you mistake it as TB or asthma or something else. So do you think it may be a good idea that anytime somebody is going in for a problem which could be related to lungs, even at an early stage like asthma or could be possible TB, people should go in for a CT scan, as Dr. Nayak said, and rule out any chances of lung cancer? And I'm specifically asking you this because we're living in an era where we are plagued with distrust. And so anytime a doctor recommends something, some test, patients take a step back and say that, पता नहीं क्यों test करा रहे हैं इस stage पे. So, what is your recommendation, and what do you think needs to be done?
No, so this question is for the clinicians here on board, Dr. Basu and Dr. Nayak. So they are more appropriate to answer this question.
So, Dr. Nayak or Dr. Basu, whoever wants to take this up.
I feel the challenge is that, yes, of course, there should be a screening program, but somehow the lung screening never picked up in India. And not even in Western countries that way. Western countries, some people have, there are multitude of problems. Say in developed nations, you have insurance policy, they dictate a lot of things. You go to US, you go to Europeans, they're more guidance based. They will come up with guidance and guidelines that it is still not very feasible. Even if you do it, it's not picking up lung cancers, too many for a low dose CT scan, like sir was saying. But in a country like India, where everything is diverse, everything from your culture to your availability of resource, so it's the government who should be taking this step. Unfortunately, they are busy in some other important things. So lung cancer, anyhow, health is not a priority, and in that, lung cancer is never been a priority. So until there is some, like for example, a bit different example is like cervical cancer in female. Now you have a vaccine which even governments endorse now. So there is a lot of awareness to it. People actually come and ask about it. This is the only way forward. So if you really want to have a lung cancer screening proper, it should be a government endorsed. Now, to answer your second part of the question, I was listening, whether there's some incidental diagnosis. So I would say after COVID, we have seen actually living in a city like Mumbai, which was very, very into peak in both the waves. We now see a lot of patients actually early stage lung cancer. Either the cardiothoracic surgeons or thoracic surgeons see it due to the post-COVID lung changes. They're not able to do surgery, some other comorbs, so they come to us for radiation opinion because it's a very important modality in early lung. So we do find that it was a routine follow-up CT scan for the COVID changes in their lung, and you incidentally pick up a very early stage lung cancer. So probably this will sort of give a hint that yeah, it has a role, because there are a couple, it's not in isolation or anecdotal. Couple of patients we have seen last 2 years that the early lung cancer actually without any symptom, it was a follow-up COVID related lung changes CT scan and detected to have an early lung.
So, Dr. Nayak, this is very interesting what Dr. Basu has brought up, because that people who had come for COVID testing or post-COVID analysis of their lungs, they realized that this is the lung cancer got picked up. Actually, I had planned asking you that during COVID, were there less number of people coming in for scans? But this is contradictory to that. So, what is your view that how did COVID impact lung cancer? And also, how did COVID impact the life of people who are already suffering from lung cancer? Because COVID was everything to do with lungs.
Okay, so what happened during COVID was CT scan was used as a diagnostic tool for COVID. So in fact, they developed a scoring system to just identify how severe is COVID. So to identify patients who need to go get admitted, to identify those who need ICU admission. So there was a scoring system. So every CT scan was used rampantly. So because of this, what happened was during that time, we had an increased incidence of detection of lung cancer also, because you are screening thousands of patients and they picked up so many lung nodules during the treatment, during COVID itself. And that, we ended up finding, a lot of diagnosing a lot of early lung cancers, and we operated quite a good numbers. So, it worked more like screening for lung cancer as well. It was the same test, what I'm talking about, the HRCT or high resolution CT scan or helical CT scan. It's the same test which I'm talking about. It takes about 5 minutes to do, and you have results in no time. So that is how it, in fact, increased the number of lung cancer detections increased. So it was nothing to do with the screening, because in India we have absolutely no screening protocol for lung cancer and leave lung cancer for any other disease. We don't have as such for any other cancers. There are very few diseases for which we have proper surveillance systems. Rest of them are not really well organized. It is very, very scanty kind of a data which we get. So that is how it is. What was your second part of the question? I just forgot. Sorry.
So my second part of the question was related to that. How did COVID impact the life of people who were already suffering from cancer?
So see, definitely a compromised lung is a problem for any patient with COVID who worsens during COVID related changes when they start developing. But if you ask me in absolute number terms, I don't think I have any such numbers to give you. But then, a patient who's already having a compromised lung will have difficulty recovering from another lung disease which is super added. So that is what would have happened for some patients. But see, overall, it is not like, we had huge mortality out of COVID when you just compare oncology cases or anything like that. It had higher mortality than normal public. But then overall in cancer, we had a lot of positive patients, but it's not like, everyone went to ICU or anything like that.
Got it. Dr. Siddharth, you were talking of technology and the work that you're doing at IIT. My question to you is that what are the technologies that are available in the current healthcare scenario to ensure early detection of lung cancer? We know that it is CT scan, but is there some development that is happening? You mentioned AI or the role of AI. So can you speak a little bit more about what is it that we are expecting?
Yeah, so actually, two significant developments. I'll quickly go over this. So one is radiomics and other is radiogenomics. Now that genomics has come big time in cancer treatment part. So analyzing the tumor and finding which mutations or changes in DNA has happened, and because of that, what could be the possible targeted therapy that the oncologist can give. But that comes little later. That comes after the surgeon has done the surgery or radiation therapy has been happened, many times. But in stage 4, of course, it comes early on, the genomic analysis. However, for screening part, there are two things which has, or one thing which because the screening has to happen based on the image analysis, right? Based on the CT scan or based on very early radiology investigations. So the issue is, either confusion based on the radiology picture as to whether it's a TB or whether it's a tumor. So can you build AI algorithms, novel AI algorithms, new AI algorithms, which can see the picture, right? So and tell that, okay, this seems more like tumor. That is one. Now the challenge there is that how for building a good AI model, you need to have very robust and very good number of data sets which are properly labeled. So let's say I have like 1,000 images of lung cancer patients. Okay, these are adenocarcinoma of lung, blah blah stage, and these are tuberculosis, right? So then you can train the AI algorithm and then it can start predicting. Same way, the second part is radiogenomics. So this was earlier what I explained was radiomics. Now this radiogenomic, we want to take another leap. That can you see the image, radiology image, and circle the area where there is tumor, which is the annotated image, we call it, and can that be utilized by AI based program or AI algorithm to predict that which gene has mutation? So can you say that, okay, based on the picture, that EGFR gene has this change, so maybe you can give RSR therapy, right? Or KRAS gene has this change, or BRAF gene has this change. So this is from radiology directly to DNA, right? So genomics, and from radiology directly to genomics. So that's why radiogenomics. So this is actually a project, and our director, Professor Shantanu Chaudhary himself is PI on this one of the projects. And this we are doing at a larger scale to predict that. So this is new development that is very recent, but India and the IITs have picked it up very quickly.
Uh, Dr. Basu, we spoke about the diagnosis of lung cancer is hidden because it is misdiagnosed as TB or asthma. Now, keeping that in mind, what as per you is the basic difference between both the diagnosis, and how does one impact the other?
If I got your question right, that you're asking how TB and lung cancer may be in disguise to each other, sort of. So
Correct.
I would say this happens. It's quite common, and more is so that people are treated like tuberculosis. They don't respond to the routine anti-tubercular drug. Maybe they thought of they're the resistant type, and then someone picks it up that no, there's something else. The challenge is that for any cancer, this is not about lung. Anything growing to a chronic phase, not resolving in 3 weeks onwards. So that suspicion should be there. It's not that every time it will lead to cancer, but then you'll get some answer. Now, it can either be an isolated episode or can be both, even concurrent. Which is also not uncommon in India. Like a lung cancer diagnosed, that patient can also have a pulmonary tuberculosis. It's not always that it is misdiagnosed as pulmonary tuberculosis and you realize they have actually lung cancer. It can be both also going on together. Unfortunately, like Sandeep sir said, that since we don't have a rigid screening protocol and we will never have probably in near future, so it's really like isolation. Like COVID, someone did for something else, they picked up early lung cancer. Or at times, like people have this executive health checkup, so you do some sort of maybe chest x-ray or CT, though chest x-ray to pick up a lung lesion will be very late. For that matter, something to be seen in chest x-ray, it's very unlikely to be early lung. It can never be picked up on a two-dimensional scan for that matter. So that's one scenario where it can be picked up, but yes, both can be also together. Then you need to treat both actually.
Dr. Nayak, would you want to add something to this or your perspective?
Sorry, I'm muted.
Yeah.
Sorry, my bad. So, so taking on from what Dr. Basu was talking about, see, some of the newer things, I think, they were talking about radiogenomics. I saw some of the projects which were trying to use just X-ray uh, and AIML, sorry, to diagnose or detect some of the lung lesions which may require further analysis. So that was an interesting project. I don't know if it was funded by Microsoft or something. I'm not very sure. So that I saw some time back. So these are many interesting things. See, as I told you earlier, the symptoms of lung cancer and all other lung diseases overlap. So and they can coexist. In fact, because see, a bad lung is a bad lung. It can get any disease. So it's as simple as that. So if your lung is bad with other diseases, it is a lung which can serve, because the etiology or the cause of many of these diseases is similar. It could be pollution, it could be smoking. So a person who has very bad what we call as COPD or lung chronic obstructive pulmonary disease, which is also caused by smoking, can have lung cancer. So that overlap really causes a lot of problem. TB also is similar. A smoker more prone to TB than a non-smoker because there is lung damage. So damage which is there can make you prone to any other new disease.
Uh, Dr. Siddharth, are there any genetic factors that are responsible for lung cancer?
Yeah, actually, if you see, cancer is a genomic disease, right? So genetic is more of like, going from one generation to other. So very few, like 10 to 15% of cancers have genetic basis. But, most of the cancers are, genomic. So somewhere in the entire genome, changes happen. And actually, after the Human Genome Project, which was, so much in light, there was a huge and, much giant cancer genome program which happened. People do not know a lot about it, the common people, I mean the lay person, but that really dissected out and that built the landscape of, if you open up an entire DNA, right, as a thread, and you just stack up, like, one patient's DNA over the other, and like, let's say you have 100 cancer patients, and then you ask a question that, okay, like, what Sandeep sir said, that, if it is non-small cell lung cancer and let's say adenocarcinoma, so where does the changes happen in the DNA? So that way you basically landscape the DNA or the genome of cancer patients. So that happened for pretty much all of the cancers, including lung cancers. And I would say lung cancer is much ahead in terms of therapeutics, right? So there is definitely genomic underlining, and that is what is exploited now by the diagnostic labs. So the like Newberg genomics, where we used to take the tissue sample and extract the DNA and figure out where the changes happen, and then a lot of therapy companies, the drug companies, they build the targeted therapies around those changes in DNA. So that, caused a whole new precision oncology as a new field. So oncologists, like, now actually they're precision oncologists, which are, targeting every cancer patient. They're segregating very finely, and then everybody is given very different therapies in a large number of cases. Not everyone, but a large number of cases.
So, Dr. Siddharth, before I go to Dr. Nayak for my next question, I want to ask you that, are Indians genetically more prone to lung cancer than people in the Western world, or vice versa?
Genetics doesn't show as I mean, if I have to give that answer very scientifically, so I would need to find what is the most common genetic change that happens in Indian population versus, let's say, population in China or in the US or Europe. So not a very significant qualitative changes seen. The kind of mutations that happen in there is definitely some differences, but not as much. So, and we cannot say that we are more prone for this particular cancer as compared to other population. Although with a pinch of salt, because the epidemiology data in India is not very easy to get, and so this making a very qualified statement is very difficult in this case.
Got it. Dr. Nayak, what is a target therapy in lung cancer that is available today? Dr. Basu, would you want to go in for that? Yeah, Dr. Nayak, your screen had frozen for some time. Can you hear us? Dr. Basu, would you want to take up this question? That what is a target therapy in lung cancer?
So targeted therapy is very simple. Like it is like you do, like Dr. Siddharth was saying, there are a lot of genomic analysis which is done in lung, and lung I would say is one side where this analysis has proven to be clinically beneficial. See, in every cancer, there are a lot of genomic analysis. You get a lot of target related to that. Whether they replicate like from bench to bedside, if you're seeing any benefit or not is very important. So lung cancer is a side where there's tremendous improvement. Like a stage 4, say in lung cancer a decade back, people would say you just have 3 months, do nothing, just try to fulfill your last wishes. In today's time, because of a permutation combination, a stage 4 lung can be a varied stage 4. If your genomic, after the analysis, some of the markers like EGFR and ALK are positive, you're non-smoker, vis-a-vis someone who is heavy smoker and a squamous cell, then there's a tremendous difference in the control or for that matter, the predicted survival. So then you find some of these markers and some drugs or agents, these are called targeted therapies overall, which can be something called in medical term tyrosine kinase inhibitors or other inhibitors depending on that. And then you administer that. Most of them are in the tablet form. So it's very easy because it's an oral administration. You can be at your home with a periodic checkup and follow up and certain tests as required. You follow up with your medical oncologist and you take those tablets or capsules as required. So these are in broad term in a common language, which is called targeted therapy. You find some target after your genomic analysis. You have certain drugs which are available with available data from different clinical trials and proven in a phase 4 research also, which has shown benefit over the placebo or just the best supportive care. You administer them and you get a clinically meaningful benefit if your factors are matching up.
So, Dr. Nayak and Dr. Siddharth. Yeah, Dr. Siddharth, you wanted to say something.
Yeah, just one point I wanted to add was, it's more of what Sandeep sir would or Dr. Basu would do, is that in certain cases, actually in the guidelines, the NCCN guidelines that a lot of oncologists use, most of them use, there actually the targeted therapy has become the first line of therapy. So for example, stage 4 lung cancer, non-resectable. So in those kind of cases, rather than going for a chemotherapy, an oncologist like Sandeep sir would most likely order a genomic test, and then based on the genomic test, going for a targeted therapy such as like gefitinib, or based on which gene is involved in it, or like let's say what Dr. Basu said about ALK gene. So there is alectinib or other therapies are there. So those are the first line therapies that have become. So it's a big change actually.
So, Dr. Nayak, does targeted therapy increase the life of a patient, or does it improve the quality of the life of whatever is left? Where does it help?
Both. As of today, both. So some of these targeted therapies are, they do have much less side effects compared to the traditional chemotherapy, though some of them have very bad side effects. So some of them are well tolerated. So target therapy does not mean that they don't have side effects. Some of the target therapies are so bad that sometimes chemotherapy fares better when it comes to symptoms. So it all depends on the response to therapy. So some of the so finally at the end of the day we look at the response and how much quality life does it add to the patient. So that is more important when it comes to any therapy that is planned. Now, so it all today, as others were also talking about, it's all about precision oncology today. Precision basically means, see, there are many ways it is emerging actually. For example, they talked about some markers, but today, there is something called new generation sequencing. I think Dr. Siddharth was talking about it. So new generation sequencing which is done for cancers, which will tell us what is the line of treatment that could best work for the given patient. So that is possible today, and that gives a that is the future of cancer probably. Tomorrow you will not ask where the cancer came from. You'll just do a biopsy. It just doesn't matter where it came from. That you send it for genetic test. The person who does the test will give you the list of drugs which may work for it, and the medical oncologist gives those drugs. So that is what is probably the future of medical oncology. I'm a surgeon, so I see the things differently. But as a talking for medical oncologist, I'm a surgical oncologist. So talking for medical oncologists, that's how it is going to be.
Dr. Basu, would you want to add to this?
So I would add, I'm a radiation oncologist. So for us also to talk about our colleagues, yeah, things would be maybe like that. The only thing is, since every branch changes, for a stage 4 lung, there are definite now surgical options also for maybe after the initial. These are all evolving. Initial targeted therapy, say a very small residual, or you have a single brain or a spine lesion, then of course the role of surgeons comes.
Yes.
Similarly, our role comes in that as well, because in today's time they're called an oligometastatic disease. So it's something like that. You have a lung tumor, but you have very limited metastasis outside the lung. There are different guidelines to call it up to 5, up to 3. That's a matter of debate. This will go on for the next decade for sure. But yes, there are clinical indications that they fare better than their other cohorts. So every branch since evolves from the previous decade. There are a lot of technological advancements. So it's going to be more maybe each patient as a patient kind of approach than a broad guideline slowly, which is something like precision oncology is meant to be. So maybe we are heading towards that era, not as a whole, but yes, in isolation for sure.
So, Dr. Siddharth, all these new technologies that come in, they come at a cost. How, where are we, and how can we make these therapies, the newer technologies being available at an affordable cost? Because you may have the best technology coming in, you may have the newest therapies coming in, but until and unless they become affordable, these therapies remain inaccessible to most people. So what is it that we can expect?
Yeah, this is actually a very, very pertinent question, Mr. Narula, because this question will keep coming to you. Most of the time, whenever you talk about precision oncology, the question comes to you. So there are a couple of things, as Sandeep sir was saying about next generation sequencing. So this is also a technology that is uh, becoming cheaper really by the day in literal sense, right? It's just like if you see your phones, the phones, every 2 years the phone size will decrease and the processing power is doubled. So this is called as Moore's law, right? So, and the cost of genomic sequencing actually is dropping at a much steeper rate than even Moore's law. So if you see the cost of human genome sequencing was in $1 billion. It was not very long time back, and now the entire genome you can sequence in about 30,000 rupees or 40,000 rupees. So this is not a day, it is not a dream, but I'm pretty sure that a time will come when, our honorable Prime Minister will say that for 2000 rupees, every Indian will get their genome sequenced, and the sequence will be stored at one central database, and a doctor, with his or her, ID and patient's Aadhaar card, they can unlock that genome sequence and can study it. And this will happen in 10 to 12 years or 15 years. So this is not very far. So all these technologies are actually becoming cheaper and cheaper by the day. The catch right now is the targeted therapy cost, because we are not really building those targeted therapies in our pharma companies. So that really costs a lot.
I think this has been an interesting conversation. I'm so glad that, all of you could take time out. My takeaway from this particular conversation has been that, one, I think there is something that needs to be done either by the government or by the private institutions to increase the level of awareness that can help us lead towards more screening, frequent screening, further leading to early detection. I think that is one area that I've identified that, why we are only detecting, or cancer is being detected at stage 4. Second is my understanding that genomics is leading to precision treatment, and that will help, better survival rates and even increasing or bettering the quality of life of people who are suffering from this disease. Before I let you go, what would be your message to people on this World Lung Cancer Day? Beginning with you, Dr. Nayak.
So the main message is that, if you are a smoker, heavy smoker, in simple words, go for an yearly screening, a CT scan. Any lab, if you go, they would be able to guide you. It's a simple CT scan. Along with, if you do regular health checkups, in fact, along with that, do a CT scan. That makes a lot of difference for you. At the same time, I think, as of today, none of the labs are incorporating, or hospitals also have added CT scan to their, preventive health check. That needs to be added, because there is sufficient evidence today, and we need to add CT scan of just as an, one of the modalities to the tests which are offered to the patients. So, that will make a huge difference, because as a matter of fact, in US, when there were not screening, about 15% of the patients only, or lung cancers, were operable. In India, it was 5%. And we still remain at around 5 to 7% as of now. So that is the status in which we are. So if we are able to screen, self-screen also, if smokers say, I want to go screen myself, I think that would make a huge difference to the end result, and we would be able to reduce the lung-related mortality or death due to lung cancer significantly.
So before I move to the next person, I have one small question. How many people who smoke will end up having lung cancer?
How many people that, no, that's a chance factor.
What percentage of people, smokers, will end up having lung cancer, or usually end up having lung cancer?
I don't think I have that statistics with me. See, I don't have such kind of a statistics with me. But if you ask me the other way around, of the lung cancer patients, how many are smokers? It's 71% to 72%.
Wow.
Other way, the flip side of it. So of the lung cancers, how many are smokers? It's more than 70%.
So more than 70% of the people suffering from lung cancer, the cause is usually smoking. Is that correct? Awesome.
oral and lung.
Got it.
Both of this, that is a cause.
Awesome. Dr. Basu, what would be your message on this World Lung Cancer Day?
So I would urge people to stop smoking. That's the first thing. Enroll yourself in smoking cessation program. There are many because it's difficult because for heavy smokers, there are a lot of other health issues once you quit smoking. So they need to be under a training program to do that. It's not that one fine day I decide that they'll end up to other troubles. It's not only about the active smoking. There are passive smokings also, that also one should try and reduce that. So as the environmental pollutants, fumes and other things, we should try and adopt as a country a go green approach in lot of things. In today's time, I see in each family there are 3 cars, which is really not needed. People can adjust their time and go to their workplace together. This much of adjustment can be done instead of trying to create more and more environmental pollutants, because we definitely see non-smoker lung cancers also, like Sandeep sir said rightly, about 25-30%. So there must be some reason. Even at times, nobody in their family also ever smoked. They are not even exposed to the passive tobacco smoking. So there must be something in the environment they are getting in. They're not even those industrial workers. They're either maybe simple housewives or in a desk job in for the males. So these, to try and reduce smoking and smoking not in the tobacco smoking in any forms, as an individual, as a country, and as a globally also, that should be the message. Know your lung, take care of your lung.
So Dr. Basu, I have one question from you also. Every message that you're giving, I have something that is coming up. So these 25% of people who are, or around 25 to 30% of people who are not the smokers, how much of it is getting affected by the pollution that we are? I mean, we know that in people living in north of India, we face a huge pollution problem. How is it impacting lung cancer, or does it impact lung cancer?
I don't have any data of that. I'm not also aware whether any epidemiological data is available to that. But a wild guess would be, see, this is my personal take. There must be something to do. How can it be? One, there's in cancer, there's always a chance factor, because cancer eventually is sporadic. It's not like this is very common for us clinicians. Many times patients and their family members think that it must be genetic. This is fed by different print media and different books that you must be having something. So it's most of the time actually sporadic. But I feel, this is my personal take, that definitely there's something. Now, having said that, even very environmental friendly countries in the world also see tremendously high lung cancers. Say Nordic country populations where they adopt so many environmental friendly approach, but they still have quite high lung cancer. Like one of the lung cancer guidelines, most of the leading people would be from Nordic countries, the clinicians. But maybe then the role of genome analysis and all those come into play. So why not? It is like rightly you see people with lung cancer, 70% will give you a history of smoking in some form or tobacco in some form. So it's like that something might happen to it. So why not try and do some step related to that, instead of trying to deep dive into data and then realize that, okay, we should have done.
Dr. Siddharth, your message on the World Lung Cancer Day.
Yeah, thank you so much, first, Harvinder ji, for calling me here. And I'm so happy to share the screen with Nayak sir and Dr. Basu. There are 3 things. One is don't smoke. There has to be some wisdom if so many people are saying it. Even if you don't understand the science, please just don't smoke. And I'll also repeat in Hindi, cigarette ना पिए, सब लोग कह रहे हैं तो कुछ तो बुद्धिमत्ता होगी उसमें. The second message I would like to say is, when the doctor says that you need to do, these words like next generation sequencing or NGS or genomic test, don't doubt. This is the latest science. The doctor is at the cutting edge doctor. You got the really the frontline doctor. or the frontiers of the science is working. So believe that and go for the testing. And third thing is, don't think that these tests, these are tests which you can do in like 15,000, 12,000, 20,000 rupees. These are not the tests that you have to send to US and you have to spend like 1 lakh or something. So don't fear that. And these are all done in India, in our laboratories. India has competent people who does all those genomic tests. It's all done here, so no need to worry about that. So these three things I would like to say. Thank
Got it.
you.
Thank you so much. It's absolutely very clear message coming from all the three panelists that do not take up smoking. And if you do smoke, quit right now. And if you are a smoker, take that 5 minutes of CT scan every year to ensure that you are not challenged with lung cancer. And if you do find yourself, if it is detected early enough, it can be cured. If it is stage 1, it can be cured. And if it is later, we now have a technology which can help you live longer, or at least, or even survive cancer. With that, I bring the session to an end. I absolutely am delighted that I had extremely great panelists, Dr. Nayak, Dr. Siddharth, and Dr. Basu. Thank you so much for your time, for joining us at BW Healthcare today.
Thank you. Thanks for having.
Thank you. Thank you so much.
Thank you.